Hi, I'm Dr. Mark King from the Motion Palpation Institute in Cincinnati, Ohio in the U.S. I want to talk just a couple minutes about plantar fasciitis, diagnosis and treatment. So it's something we're going to see a lot in our offices. Kind of a dead giveaway on this is heel pain after sitting for a long time. Obviously in the morning when they get up to get out of their bed and walk to the bathroom. That's a lot of heel pain. That's a tough one for them, and that's a common sign with this plantar fasciitis problems. Tenderness calcaneus on the plantar surface. You want to try and do, when there's supine, you can do a medial and lateral compression on the calcaneus. The idea of that test is to rule in or rule out a stress fracture. It's not 100%, well, none of the orthopedic tests are, but it gives you an idea. If that's particularly painful and pointed, that makes you think a little bit more about a stress fracture, and that's a different animal, a little tougher to treat, obviously, and requires some rest, so you need to rule that out. You need to find out if this foot is too stiff, too loose. Is it supinated with weight bearing? Is it pronated with weight bearing? Because that changes your treatment. If it's too stiff, too supinated, a cavus foot, you're going to get in there and adjust it more and typically do even more stretching. So you think about it from a joint dysfunction, you adjust the areas that are dysfunctional, think about that locomotor chain. We divide the plantar fascia from the gastrocsoleus, but as far as our brains, it's just one continuous locomotor chain, with the gastrocsoleus down into the calcaneus, into the plantar fascia. So think of it that way, meaning that when you do go to do your soft tissue, you're doing this entire chain. You're doing work on the plantar fascia and getting up into the gastrocsoleus, even tibialis posteriors with your soft tissue work. So X-rays will often show a weakness, X-rays will often show a spur. What I was about to say about weakness is that the foot being weak is a big sign, obviously, that we need to rehab the foot more. You can do the wink sign that Dr. Michaud talks about, and if you do an MRI, that'll give you an idea of if there's a stress fracture, if there's a tear in the plantar fascia. So from a treatment standpoint, I already talked about being comprehensive with soft tissue. I already talked about doing your adjustments for that stiff foot. From a rehab standpoint, we are biased. We like DNS, the DNS approach. We love what Dr. Michaud does, and I have a Toe Pro here that we can use with our foot flexor activation. So if you go to humanlocomotion.com or mytoepro.com, it'll give you some of the information about that. You can use this for stretching of the gastrocsoleus. Obviously, you can use a slant board. You can use a step in the house. There's multiple ways to get that stretching, but that's typically going to be an important part. You check the length of their gastrocsoleus. If it's not short, well, then that's not going to be nearly as helpful. From a passive standpoint, dry needling, cold laser, radial pressure wave, shock wave, those are all helpful. A lot of you out there will get people in orthotics or will tape the foot. That can be very helpful. From a surgery standpoint, there was a time when they would cut that medial 1/3 of the plantar fascia. That was not a good long-term solution. I really never hear about any surgeons, foot and ankle surgeons, doing surgery on chronic plantar fasciitis anymore. Rarely do I even hear about them doing cortisone anymore. Occasionally, but not very often. If they're not progressing, get a second opinion, get an MRI, get your X-ray, whatever. Look into it further. But these can be stubborn, so you have to put them on a treatment plan, do your treatment based on your really thorough exam, and then stay with it. And good luck with these patients. Thank you.